and welcome everyone to our February WebEx. It's fantastic that you've all joined us, and I think it's a special WebEx in the fact that it's really our last in the current series of inviting boards to come and be guest presenters to share their work that they've been doing to reduce medicine's harm across transitions. And it's an absolute pleasure to be welcoming NHS Tayside as our presenting board today. So a few housekeepings before we do get started. We really do appreciate your time and commitment to these WebExes, and we're here today to really support the learning and sharing between boards regarding MedRec across the whole system. And we really want to challenge our thinking in terms of what is our theory for improvement and what tests of change have actually resulted in improvement. But before we start into the sharing, just a few points, as Sarah's already pointed out. If you're not presenting, your phone is automatically on mute, and that's just to reduce any of the background noise that we are likely to pick up on a busy WebEx. But in saying that, we are keen to get your opinions and your thoughts. Please be open to learn and share based on what you're about to hear from Tayside. And please use the chat box, as some people have already done so, to help with the discussion and type in any questions that you have. You'll see that people have already been kindly introducing themselves, so if you've not done that yet, please do use the chat box to let us know who you are and where you're working. And we've already noticed that there's somebody lurking and willing to learn, which is a fantastic way to be. Just to confirm too, there will be time at the end of the WebEx for question and answers with the presenting board, and we'll actually unmute all of the lines then to allow a bit more of a conversation. And we will be monitoring the chat box to make sure any of the questions are picked up during that time as well. So for those that have not used the chat box before, please make sure that when you select the chat box, which is that circled up in the blue icon on the screen at the moment, please make sure you do select all participants. If you don't select all participants, you might be having a private conversation with either myself or the host, but we really do want to make this an all share and all learn. And as I mentioned before, this WebEx is being recorded and is going to be made available on our SPSP website probably at the beginning of next week. So Medicine's program within SPSP really aims to bring together all the improvement activity that's been happening, and it continues to happen across all care settings with acute care, primary care, maternity and children's services, as well as mental health. And it's great just looking at the chat box. We've already got representation from pediatrics, mental health and a community pharmacy as well, just as a broad representation of the people we work with. We do really think that SPSP Medicines provides a unique opportunity to consider the safe use of medicines from a whole system approach, focusing on the patient as they move between care settings and home. And I think it's fantastic today that NHS Tayside are going to be sharing a true whole system perspective when it comes to medication safety in their board. Our focus as a program over the past 24 months almost has been around reducing medicine's harm across transitions, looking at those medicines that are considered high risk, and we're now also moving into the concept of medication omissions and the potential opportunities to improve that. And I think it's a fair realisation that all of these things are linked, and it's something that we can't really be looking at in isolation. Again, reinforcing for us that whole systems or whole systems thinking in our approach to ensure safer use of medicines. But back to transitions, we have our theory for improvement, which is our driver diagram. And again, it would be good today if we can listen out from our colleagues in NHS Tayside, how they're addressing some of the primary drivers around person-centred care, perhaps some of their teamwork and communication across the whole system, as well as some of the systems and IT infrastructure that they're using to support their work. And we'd be really keen to get some reflections of everybody else in the chat box as well, in terms of how that resonates with the work they're involved in their board. So without further ado, I think it's really kind of important that we reflect on some of the experience past. This is the last in our current series of WebExes, but we've been documenting and sharing every month the key learning from each of the WebExes. And those that were able to join in January, we heard from Dumfries and Galloway, and they were able to share some great work around a particular funded project with the Health Foundation around implementing an electronic medicines reconciliation system. And hello, Paul, just as you've joined, we are talking about your board and in fact your presentation from last month, so you're most welcome. So for those who have not seen it, that's a document that we do update every month and is available on our website. So it's my absolute pleasure to introduce Deirdre Cameron, who's going to be coordinating quite a team today from NHS Tayside, who are going to be running a relay race in their room as they present their work. So it's an absolute pleasure to pass over to Deirdre Cameron.
Hello, and you've actually passed over straight to Maureen Lafferty, and as David has said, we are probably trying to demonstrate a multidisciplinary team approach to our presentation today, and I hope you bear with us as we change speakers throughout the presentation. So this is a picture of one of our beautiful Angus glens, and we're not planning on putting a Donald Trump golf course on it, but we do recognise that we need to change what we're doing with medicine safety. That's not to say that we've not made great progress, but we're needing to, I think, reboot and think how we can go to the next level. So some of that is in recognition that we don't always make it easy for ourselves, and we're working in silos, and somebody makes an improvement and it's difficult to share that across the system. Some of it is getting bogged down in some of the governance structures, and that's what happened to our new insulin charts, round and round the houses trying to find a way through, and we're hoping that some of the changes that we're going to make will smooth the process for teams in the future. A lot of work has maybe been done on looking at past harm, and it's about, we're trying to maybe change the focus of looking forward and at the present when we're looking at medicine safety. And it's about not just making measurements for assurance, but as you're making these measurements, to ask, what could I do differently, what can I learn from this, rather than just having a number at the end of the day, which is obviously applicable to many strands of the work that we're doing. So I didn't attend the ADTC event in November 2015, but a delegation from NHS Tayside did. And they came away, I think, probably with more questions than answers about what to do, and they set up a group to think about where does medicine safety sit within the structure of the organisation, and how can we take things forward. The patient safety team, prior to this, had taken a survey of staff, and the staff themselves had identified 3 areas that they wanted to work on. One was medicine safety, one was a deterioration patient, and the other one was MDT communication, and there were 3 patient safety work streams already set up. Within medicine safety, it's very interesting because the frontline staff, what they identified themselves was high-risk medicines, omissions and medicines reconciliation as the priorities that they felt we should be working on. So that was already identified by the clinical teams on a survey. So this expert group met and thought about how we could take things forward. How do we move our SPSP work on medicine safety from a project or from the sidelines into core business? And they recommended setting up a medicine safety and quality subgroup of the ADTC, and they took that proposal forward to the ADTC for agreement, which was approved. And this is where we sit within the ADTC's framework, and you can see lots of subgroups, and we are now sitting among them. We've got a wide remit, and I won't read you. When I first read the terms of reference, it seemed a bit intimidating, but we have. I can give you some examples. So one of them is to provide clarity to the organisation for the current landscape of medicine safety and quality and programmes across NHS Tayside, including the data collection. To think about whole system pathways across NHS Tayside, and to try and articulate a whole system vision for medicine safety and quality. And sitting underneath the ADTC gives us a governance framework, but also gives us somewhere to go to if we're meeting barriers, and to have their support in taking issues forward is really helpful. It's early days, but I think I'm very optimistic that this will be a success. One of the areas at the moment where we'll be working on is obviously the medicines policy group will be responsible for a medicines reconciliation policy, but obviously we, as the team that are working on medicines reconciliation improvement work, would feel that we have a lot to contribute to that policy, and we would obviously be working side by side with them on that particular issue. And in fact, it's interesting, at the last ADTC meeting, medicines reconciliation seemed to be a key theme under many of the headings. So I think it's quite right that we sit within the ADTC framework. So if this plan to change works, how will we know we're successful? Then I think there'll be clarity for medicine safety across the organisation, within managerial committees, within clinical governance committees, within frontline staff, that we actually get the message out there, that we educate our staff to see, not just to be accepting or measure just for assurance, but to start asking questions. And I think it really is to be shifted to a core activity as opposed to something that we do as a hobby. So I'm now going to pass you on to Debbie Voigt. Oh no, I'm not. This is a picture of my brain, and I think it just emphasises how complex medicine safety is when we're trying to make a difference. And our thinking now is that we want to try and have a whole systems approach when we are looking at medicine safety, a whole systems approach from a patient's perspective. And to illustrate that, we're going to share a patient story with you and some of the work that we've done.
Thank you. So my name's Debbie Voigt, and I'm going to tell you the story of Morag. And Morag is a real patient. She's 74 years of age. She has type 2 diabetes, which is long-standing, and she's treated with insulin. She's normally treated with Insulatard twice a day, which she self-administers at home. She's got an HbA1c of 45, which suggests that her blood glucose control is very good, and potentially this lady's at risk of hypoglycemia. Her renal function is deteriorating, and her last recorded eGFR prior to admission to hospital was 15. Normally she's socially independent, her family lives nearby, and she manages things herself. Morag had been unwell for 48 hours, called for GP advice, and she'd been reviewed by the NHS 24 at home. They decided that she should be transferred to hospital, so she was taken by ambulance to an acute medical admission unit in Ninewells. She didn't bring any medication with her, so the ECS was checked when her prescribing was being reconciled. And on the ECS it said Insulatard as directed, which is often the case with insulin because people change their doses. And she was also prescribed glycoside 80 milligrams twice daily. So these were her diabetes medications. The patient reported her insulin doses to the doctor, and these were prescribed on her insulin prescription chart and her drug cardex. And Morag was subsequently diagnosed with urosepsis. Diabetes specialist nurse was asked to review Morag on the ward, and a prescription error was identified. And the prescription error was identified with the help of Sky Diabetes, which Sky Diabetes is an electronic record for each patient who has diabetes in Scotland. So all their clinical markers, their prescribing details, their reviews at the diabetes clinic are all recorded on this electronic system, which is fantastic, except that it's not open to generalists. So it's the specialist diabetes teams and the GPs who have access to this system. So Morag was prescribed insulin 4 times a day on her insulin prescription chart instead of twice daily. From Sky Diabetes, we knew that the glycoside had been stopped at the diabetes clinic 2 weeks prior to admission because of her low HbA1c and because of her renal function. Morag had been asked about her insulin when she came into hospital, and she said that she took insulin in the morning and at night. She sometimes got up late, so she took insulin at lunchtime, and she always took insulin with her tea. So the doctor who was doing her prescription prescribed her Insulatard 4 times a day instead of twice. Nurses were administering Morag's insulin in hospital, and she was getting insulin 4 times a day. She did run into some problems with hypoglycemia. And it was interesting that the relatives had reported that Morag had been a little confused of late at home. Following this review, we changed her insulin to twice a day, and we stopped the glycoside. I'll now hand you over to Siobhan.
Thank you, Debbie. I'm Siobhan Reid. I'm lead clinical pharmacist at Perth Royal Infirmary, and I'm actually taking the place of Andrew Parker, who is our Scottish Ambulance Clinical Governance Manager, who I undertook a project with at PRI. This project was sparked by some comments from medical staff that patients never came into hospital with their inhalers. And it just kind of grew from there about getting patients to bring in their own medicines from home, and that we decided to work with the ambulance service to try and improve the amount of medication brought into hospital when patients were admitted by ambulance. So the aim of our project was by December 2015 that 95% of patients brought in by ambulance from their own home, admitted to Ward 4 at PRI, arrived with their own medicines. So we had 4 goals. One was to decrease the number of missed medication doses in Ward 4. 2, to improve medicines reconciliation for patients admitted to Ward 4. 3, decrease the number of prescribing errors. And 4, to reduce waste and additional supply of medication. We designed process measures, outcome measures, and balancing measures. I won't run through them all, but you can all see them on the screen. And we set about collecting all our data, which is currently ongoing. The next slide shows a couple of charts. These are Andrew's speciality P charts, so I won't go into these in detail, but they show the percentage of patients brought in their own medicines when they were brought in by ambulance, and the percentage of patients brought in by ambulance with 1 or more missed doses. Our more recent data of missed doses actually shows this is one of the key areas where we actually have made an improvement with this project, and the number of patients with missed doses has reduced in the last few months. And I'm going to hand on to Gordon, who is going to take you through the medicines reconciliation story so far.
Hi, it's Gordon here. So we're just taking a slight deviation from Morag's story just to reflect on what we've done in NHS Tayside. And as you can see here, we've been at this for quite a long time now, which I think reflects on how difficult the whole process is and how complex it is. So what we've managed to do so far is to implement reliable systems in our acute admissions units in our hospitals, and we've also spread a medicines reconciliation process to most of our inpatient areas. That includes acute hospitals, longer stay hospitals, community hospitals, but we don't have a level of reliability across that whole system yet, despite working on it for all this length of time. Another success is that in the past, because of the nature of the SPSP programs working in different work streams or silos, if you want to call them that, different tools had been developed, so it was quite difficult to look across the system to compare what was good in one system might have been more linked to how it was measured rather than a real difference. So we've been able to develop one single measurement tool so that the measures we capture on medicines reconciliation are the same across the organisation. Other successes are that we've been part of all the SPSP programmes, so we've had a go at all of it, except for the community pharmacy, the newest one, and we've not yet had an opportunity to participate in that because it's not gone across all boards. Another success for us is to try and move away from this medicines reconciliation equals pharmacy descriptor. So we've now had a number of junior doctors and medical students involved in data collection and some small-scale improvements in clinical areas. So That's about sowing the seed for the future, I guess, and that if they're involved at an early stage in their career, then they'll have a better understanding of the issues and be more likely to engage as they move into more senior positions. And Maureen's already mentioned that although we've been working on medicine safety and medicine reconciliation in particular for some time, it always sat outside our main governance structures within NHS Tayside. So just within the last year or so, we've now reorganised all that structure, as Maureen showed you in that quite complicated diagram. So now all the medicine safety sits inside the medicines governance structure, so it becomes a bit more business as usual rather than something that's separate. And I'm aware that other boards have done similar things as well. I think also within the last year or so, we've linked to this whole systems approach, we've had an event where we had stakeholders from across the whole system, including patients, and that's given us a bit of a better understanding of the complexities, but also a better understanding of how to move forward with dealing with some of the issues around patients and their medicines as they move through the system. Sorry, so I apologise for the delay. I'm just working out how to move to the next slide. Oh, managed. So that was a challenge for me. Here were some. Now, you will be familiar with all of these challenges. I don't think any of these are unique to Tayside. So we still have, despite what I said about junior medical staff and students, as a broad statement, we still don't have enough medical staff and probably nursing staff engagement in terms of dealing with the medication safety agenda. I think people were getting a little bit fed up with the term medicines reconciliation, and again that's recognised nationally, and so Healthcare Improvement Scotland are rebranding that, and similarly we're trying to refresh and rebrand it in Tayside so it becomes something that people recognise as important to the care of their patients rather than becoming seen as a chore or something we need to collect measures around but we're not really making much progress with. We still have challenges about communications at the interface, and I'll come back to that on a later slide. We also still have variation in our processes and documentation, and Drew Henderson, who's one of Maureen's colleagues, is undertaking an exercise to try and move forward with that as part of our e-health agenda, and I think that will be how we will address that challenge. And I've already mentioned the pharmacy-dependent process. I think we're beginning to move away from that, so that will become less of a challenge as we move on. So I'm now going to hand you back to, I think, Siobhan again.
Okay, so Debbie told us about Morag's story, and I've told you briefly about a bit of work that I've undertaken with Andrew from the ambulance service, where we put in green bags into the ambulances and did some training with the paramedics about the importance of bringing in patients' own medicines to the hospital. However, it's important for us to understand how the improvement work we're doing actually relates to reducing patient harm and improving the patient's journey. So in Morag's case, how could current improvement work have ensured a robust and reliable MedRec process and improved her patient journey? Well, if the ambulance service had brought in the patient's medication, this acts as a useful prompt for discussing medication with patients and carers, and it may have helped elicit a better medicines reconciliation given Morag's recent confusion. Also, the paramedics may have been able to bring in any handheld insulin dosing record that was present in Morag's house. This may have provided accurate insulin dosing and information on the discontinuation of gliclazide. Sorry, I'm having a technical issue with moving the slide on. Okay. Although not an issue in Morag's case, but recognised as an issue for many patients admitted to hospital, is missed doses. Given the sheer number and variety of medicines available, it's not possible for our admitting wards to keep sufficient stock to prevent missed doses. If more patients bring their medication to hospital, This will reduce missed doses on admission. This is an area of the ambulance service project, as I previously mentioned, where our data shows improvement. In April 2016, PRI held a rapid improvement event looking at patient flow through PRI from the point of referral to the point of discharge to a stable environment. As part of this piece of work, we highlighted the need for a standardised admission document. And as Gordon already mentioned, I did some work with our secondary care colleague, Drew Henderson, where we were looking at improving the information that was brought in with the hospital and standardising the admissions process from primary to secondary care. What we looked at was utilising the GP system for making electronic referrals, which is Sky Gateway in GP practice, which refers into RMS in secondary care to produce an electronic referral for emergency admissions. The idea that this could be formatted as a current Clarkin document, automatically populated in GP practice and printed in secondary care, was developed and aimed to reduce transcription errors, save time and improve medicines reconciliation. And it was only through discussion with my Safer Patient colleagues that we highlighted that similar work was also being cultivated in Ninewell. And at this point, the idea is that we're on hold in PRI while we wait for the implementation of track care. Then both parties can work together to improve the idea of the transfer of information electronically. I am now going to hand on to Debbie again.
So if we look at what we've been doing to improve insulin prescribing in NHS Tayside, it's been quite a long journey. We've been doing this project for quite some time, but come April, we will implement our new insulin prescribing and administration record, kindly known as the IPAR. We have a paediatric version for those of you working paediatrics, and we've kindly called that the PIPAR. And this chart was developed to improve safety in prescribing insulin, administering insulin, and the storage of insulin, because we know these are all issues, and I think there are issues in each hospital across Scotland. The IPAR has a diagram on it, as you can see, that has a time-action profiles of insulin, so it allows prescribers a better understanding of how insulins work and how long they work. It also demystifies some of the insulin because it clearly represents that we have short-acting insulin, long-acting insulin, and mixtures of insulin. And in Morag's case, the Insulatard, the third one down in the green, it would allow the prescriber to see that the Insulatard has a time-action profile of about 8 to 12 hours, so twice a day Insulatard was probably sufficient, not 4 times a day. Also within this time-action profile chart, you've got the names of different insulins, so lists suitable alternatives if the insulins are not available. Within our insulin chart is guidance on insulin administration for nurses, who support self-administration, guidance for patients who wish to administer their own insulin, and because we've got a significant number of people using insulin pumps, we've added some insulin pump data to this. We've tested the IPAR using improvement methodology. We've received positive feedback from a range of healthcare professionals on the design, the guidelines within the IPAR. We have guidelines for hypo and hyperglycemia. And one of the main features is the fact that units is pre-printed, and this reduces the error of the abbreviation I or IU being used and being misread as a number. I'd like to now pass you on to Shadi.
So, as Morag gets ready for her eagerly awaited discharge, we know that we need to continue to work together as a multidisciplinary team to organize a number of things for Morag. And that, of course, includes her discharge prescription. Morag's discharge is, in essence, just a transition of her care between the secondary care teams here in the hospital and their primary care colleagues on discharge. And this transition of care therefore necessitates a reconciliation of all her medicines. That's to ensure that she has a safe, a smooth and a seamless journey, because we know that medicines reconciliation improves patient safety. But what we also know is that our MedRec on discharge process, at least here in Tayside, could be done better. There was certainly room for improvement. And upon closer review, we found that one of the contributing or the potential contributing factors to this is that the junior doctors here in Tayside, at least, had really poor compliance with using multiple sources to reconcile the patient's medicines at the point of discharge when they're generating a discharge prescription. We found that most of our junior doctors were only using the patient's inpatient prescription chart, or what we refer to as the TPAR, to generate the discharge prescription. Very few of our junior doctors were actually complying with our local policy, which necessitates that they use two forms or two sources to actually reconcile the medicines at the point of discharge to help generate an accurate discharge prescription. And this was not only increasing the risk of harm because of the numerous errors that were frequently picked up and corrected by the ward pharmacist as they were reviewing the discharge prescriptions before the patients got discharged, but it certainly was causing a lot of unnecessary delays because of the time it then took to correct all these errors. As a result of this, we decided to explore ways in which we can support and help the junior doctors comply with our local policy and ensure that the patient's medicines reconciliation form from the point of admission is actually used alongside the inpatient prescription chart to help generate a discharge prescription. And what we found out is that actually a very simple yet very effective intervention was to dedicate a specific section on the medicines reconciliation form from the point of admission, where not only the junior doctors, but also pharmacy members of the multidisciplinary team can actually endorse that they've reviewed the contents of this medicines reconciliation form as part of their discharge planning process. And this also prompts them to ensure that they communicate any changes in the patient's medication history, not just to the primary care colleagues, but also to the patient themselves at the point of discharge. Now, the contents and the details of this project was actually shared in a previous WebEx and in one of the recent national SPSP events, so I'm not going to go into too much of the details, but I just want to maybe touch on a couple of things. One that Gordon has picked up on is that we certainly planned and delivered this project as a multidisciplinary project between pharmacy and medicine in terms of junior doctors. It was not just delivered by pharmacy. It was designed to be delivered as a multidisciplinary project between pharmacy and junior doctors. And it certainly helped us deliver a sort of a system, if you like, where the accuracy of the discharge prescriptions that you can see are almost 90% accurate most of the time prior to any pharmacy input. So it's 90% accurate prior to any pharmacy input. And it also incorporates, as part of this definition of accuracy of a MedRec on discharge, that the GPs or the primary care teams are actually informed of any changes in the patient's medication history and the reasons for that change. And you can see again from the data that that was done reliably 90 or 95% of the time as well. So going back to MORAG, what we have now is a system that actually benefits all members of the multidisciplinary team, but especially MORAG herself. We have a system that now helps ensure that MORAG's discharge is safe, timely, but most importantly, it's actually patient-centered. It's safe because the junior doctors are now guided and supported to refer back to the medicines reconciliation forms from the point of admission and use them as one of the essential sources they need to reconcile medicines and generate an accurate discharge prescription. And it also prompts them to communicate any changes in the patient's medication history to the primary care colleagues as part of that process. It's timely because, obviously, with less errors in the discharge prescription, it is much quicker for the pharmacy team to clinically review these prescriptions before sending them to the dispensary for dispensing and supply of any medicines that are needed for MORAG at the point of discharge. But most importantly, it is patient-centered because any changes in MORAG's medication history is not just communicated to the primary care team at the point of discharge, but it's actually communicated to MORAG herself as part of the counseling process that's prompted by the addition of the redesign to the medicines reconciliation form. And I think I'm now going to have to hand you over to Gordon.
sorry, I was a bit delayed there because I thought there was one more slide to go. I'm just going to skip this slide onto the next one. Right, so the good news, folks, is that this marathon baton passing process is almost finished now. I'm the last guy. So, we spoke earlier about the landscape in Tayside, and what you can see now in this diagram is a picture of the Dundee waterfront, which is currently undergoing transformation. And that futuristic building, it looks like the bow of a ship, is the V&A Museum, which, if you don't know, is moving to Dundee and is due to open in 2018. Now, if you were to come to Dundee today, you wouldn't see that picture, but you would certainly see elements of it. So I think we're describing our current position or our landscape in Tayside with regards to medicine safety is a little bit like the Dundee waterfront project. We've now got a better picture of what we think it needs to look like following our stakeholder event. We've got a clearer understanding of how it needs to be more joined up, but we've still got work to do. Now, as we've gone through the presentation, we've alluded to various sources of information and sharing of information, and I think in Tayside we've got reasonably good systems of doing that. On screen is just a screenshot of our electronic discharge document, which you may have heard me speak about before, so I'll not go into the details, but the benefits we see are we're able to move into this system medicines from the GP practice. We can do that electronically and then electronically send that information back out to the practice. However, our e-health systems aren't yet joined up enough to tackle the whole system that we've described before, and we realise there's work to do there. We are able to share some information, but not all the critical clinical information across the system. And if the whole system is truly going to work together safely and collaboratively, then we really need to all be sharing and accessing the same information, irrespective of where the patient pops up in the system, whether it's in an acute hospital or in their own home or in a GP practice. So that is definitely work that's ongoing. What we are encountering are some barriers to that around the governance of these processes, and that's something that we locally are trying to tackle, but we also think we need support from Scottish Government and others. So I'd be interested to hear if anybody raises this in the questions, but this is an issue that we would definitely like to have discussed at the Medicines Reconciliation Summit on March the 2nd, which I'm sure some of you will be going to. So we've talked about the whole system approach. It's not just talk, we have a test in mind, and we're going to be working with one of our GP clusters, working with the practices and the patients in that cluster, and working to do improvement work around patients and their medicines as they move through the system, whether it's within the cluster, in and out of hospital as an inpatient or an outpatient, and looking for specific improvements to do to bring together all the strands of the improvement work that we've previously done as separate pieces of work, but move forward with that in a more joined up, integrated approach within the health and social care partnerships as they begin to evolve. So we're going to stop now, and we'll try and take any questions that we can, and if there's any difficult questions, obviously I'll pass them on to my colleagues. Thank you.
Gordon, thank you very much, and thank you already for your process of delegation. But can I just extend thanks to the broader team in Tayside. Gold medal for relay racing, I'll leave that for everybody else to decide, but we really do appreciate all of your time and commitment to getting through a really good overview of what's happening in Tayside. There have been a number of questions come through in the chat box, and I think some of them may be worth picking up just now, and some of them I think too might be worthwhile for some discussion, as you've alluded to already, Gordon, that might be picked up in March. But if we go back through, there have been a couple of questions around what the green bag system is, and I think it's fair to say there's been quite a good lot of responses to that. Can I check in terms of my own learning? Green bags look like they're not just limited to Scottish Ambulance, they in fact can be used anywhere in the system. So our team in Tayside, how are the green bags currently being used in your board?
There are two sizes of green bag that we use. The small ones, which are utilised quite widely by our accident emergency units for when patients come into accident emergency and for transferring medicines to patients on the ward. And we've also introduced a larger green carrier bag for the ambulance service to use. So they use both sizes, just depending on how much medication the patient actually has at home. And you just use whichever ones is most appropriate. So the small green bags are used more widely, and the large green bags were just, as far as I'm aware, we just use them for giving out medications from pharmacy and for the ambulance crews to bring in large quantities of medicine.
Thank you. Sarah, can I ask, as our host, would you mind opening all of the other lines now just to allow other people to comment? Because I'd be keen to get others' reflections on where they're also using green bags, if it's an ambulance initiative or are they being used elsewhere?
Shadi's just telling me that in Ninewells they use them for transferring medication between wards as well. So. Okay,
excellent. So everyone else that's on, this is your chance to speak. Are there any other uses of green bags that people would want to share just now?
I mean, we certainly use them across all wards in Lothian, and they're particularly useful for that kind of reconciliation at the point of discharge. So that's one of our kind of main uses of them as well.
In the pre-operative setting as well, if you've got somebody who's come due in for a planned procedure, they can get given one and ask to bring their own meds when they come.
Oh, brilliant. So can I ask, sorry, I knew that was Gillian from Lothian. Who was just commenting then around...
It was Caroline from Lothian.
Oh, hi, Caroline. Sorry, I didn't recognise your voice there. Thanks for that. So I guess it's a good learning point in terms of just those being resourced. I think there was a comment made that the actual procurement of those sometimes might be a bit challenging, the cost, but we might move on from that. Gillian, you also asked a question in the chat box too, just around the insulin chart. I'm just wondering, did you want to direct that question to Debbie?
Yeah, I mean, the chart looks fantastic. We've really struggled with getting insulin prescribed and given at the right times. I think when we audited it a few months ago, about 80% of our breakfast insulins weren't prescribed in time for the patients to get them with their breakfast. And I know that you guys were maybe looking before at this kind of fixed prescription, and I wondered if that's the way that you have gone with your IPAR.
There seems to be two models of insulin prescribing across Scotland. One model is insulin prescribed on a daily basis. Here in Tayside, we prescribe insulin on admission to hospital and only change it if it needs to be changed. So it is a fixed prescription, but the blood glucose levels should be reviewed each day and the insulin adjusted if necessary. I think the feedback that we have from health boards where they prescribe insulin on a daily basis, does seem a recipe for delay, patients not getting their insulin in a timely manner and sometimes insulin omission. And I think a lot of it is transcribing rather than looking at blood glucose levels and planning a good adjustment. So we're great believers in fixed insulin dosing and only change the prescription if necessary. The same as you would with an oral medication.
Absolutely, yeah, we'd be really interested to test that over here. I think that would be a fantastic move for us in terms of patient safety and person-centred care.
Thank you. Debbie, I was keen to sort of learn a bit more too. You commented around the Sky Diabetes being essentially an information source for specialists to access. Is that something that is being explored for further access? And am I right in hearing that you mentioned the fact that it would be the GPs and the specialists and the patients themselves being those only able to access at the moment?
So at the moment, Sky Diabetes is an electronic record for everybody who has diabetes across Scotland. So patients themselves can access their records through My Diabetes My Way. They have to register there. Then they can see all their clinical data and in some cases their clinic letters. The GPs can look at all their patients who have diabetes, and as a specialist team we can see the whole of Scotland if we register interest in a date of birth and CHI. So say for example somebody from Edinburgh is on holiday here and they come into hospital, we can access their diabetes record, the specialist team can access their diabetes record. We plan to share all the clinic letters on our clinical portal, so that will allow the generalists and in particular the acute medical admission staff to see what's happening with with a patient in relation to their diabetes. So we just need the electronic systems to be linked up, and all the work has been done. But I think because we're changing from Topaz to Track Care here, everything's kind of standing still, waiting for Track to come along.
It's sort of just a bit on hold at the moment.
Yeah.
Yeah, okay, thank you for that. I'm just scanning through the chat. You'll see our team from Tayside, there's been quite a lot of chat going through while you've been talking, which I think is absolutely fantastic, which we'll be able to send to you afterwards as well for your information. There seems to be a lot of chat around what the green bag system was, and I think we've covered that quite well. There's been a few examples of what's being tested IT-wise in other boards, and comments around information governance, which again, Gordon, I think you've picked up as a local issue, but also potentially something that might require national attention. For those others on the call, can I check, are there any other questions or comments you'd like to make now? I know all the phone lines are open, so it's your opportunity to speak. Silence is often all. Yeah, go ahead, please.
It's Keith Burns here. Sorry.
Hi, Keith.
Just what system you're using that manages to import the GP medication into the discharge summary? I was quite interested in that sort of thing.
Yeah, it's an in-house developed system. It's not commercially available. So we are able to import into our electronic discharge medicines directly from the GP. It's mainly vision that GPs use in Tayside. So we can import the medicines directly into the discharge prescription electronically, so it minimises all the transcribing and the potential errors. So facilitates the med record.
Particularly as we move to HEPMA eventually, that would be a good thing at the front end of the admission as well, wouldn't it, to take that. But that's interesting, thank you.
Yeah, I mean, the problem is there isn't any commercial system that we're aware of, any HEPMA system or any other system that is able to do that reliably. So it seems an obvious thing, but no commercial systems are currently able to do this reliably, or at least none that we're aware of. If anybody knows of one, we'd like to hear about it.
Sure. Yeah, we haven't found one.
Good.
Okay. Thanks, Keith, and thanks for joining us from the Western Isles. That's appreciated. Are there any other questions from those on the line or in the room? I'll take by the silence. I think everybody's either completely satisfied with what you've presented today or still stewing over some of the key issues. But if I can, again, just thank everybody from Tayside for sharing today. It's really much appreciated. Before we do close the WebEx, I do want to pick up on the summit that Gordon has rightly pointed out, which is happening on the 2nd of March. So it's in recognition of the fact that we've held an event in February 2016, and we really wanted to bring everybody back together again as an opportunity to reflect on some of the key issues that we've been hearing about predominantly as we've gone through this WebEx series and also visiting boards. For those who are not aware, we're going to be hearing from Jane Smith, who's a Medication Safety Officer working out of the North Bristol Trust in NHS England. And she's going to be sharing their journey, which I think has got a similar timeline to some of the work that's been described in Tayside, starting back in 2006, 2007. They've published a review of the work, including cost savings around the meds work they've implemented within their trust. But we're also going to be covering some, I think, what essentially are the key issues or areas that people have been discussing the most over the last 12 months. We're really wanting to have an open debate around the roles and responsibilities when we think about healthcare professionals in the context of medicines reconciliation. We really want to have a discussion around information governance and IT, and again, picking up on your point, Gordon, what opportunities might there be for a national position on the sharing of information across Scotland, and it'll be interesting to see how that discussion goes. And I think most importantly too, we're really wanting to have an opportunity to generate unique ideas of how we genuinely involve patients in this process of medicines reconciliation. I think we've said it before, when we think about a whole system, the two constants are the patients and their medicines. So it's how will we meaningfully bring those two things together as to ensure that we can do medicines reconciliation reliably. So registration closes next week. In fact, this time in 2 weeks, the summit will be over, and for some that may be a relief, but we are very much looking forward to hosting the event on the 2nd of March. If you are interested in going and haven't registered, please contact your program manager, and for more information you can go to our website. So we mentioned too that this is the last of the WebEx in this current series format. It's not to say that we're going away. We will be hosting a WebEx on the 16th of March as a teach back for those people who aren't able to come to the summit. So again, we'd ask that you promote that with colleagues. We're just going to use the hour to summarize the key points and what really happened on the day. But after that, we're really going to be looking to you to help shape what happens in the next year. We're keen to support any form of sharing and learning across the system that we can nationally, but we'd really like to hear from you in terms of how we best do that. And if we were to host a WebEx series, what is it you would like to be covered on those WebEx? So we'll be contacting you, seeking your feedback in the near future. So without further ado, I'd like to thank everybody for joining today, and again thank Deirdre and the NHS Tayside team for their presentation, and these will be available early next week on our website. So thank you all very, very much, and we hope to see you on the 2nd of March.